Today, it's Neurology Morning Report and recording is in progress. I hope everyone is doing well, and you know the routine. We would love to have someone present a neurology case if someone had a case they were hoping to present today, and have two discussants, ideally one identifying as a woman and one identifying as a man. So does anyone have a case? If not, we will probably be able to find one amidst our CP Solvers Neuro crew, but if anyone brought one and was hoping to present. And otherwise, two discussants. Was anyone hoping to discuss a neurology case this morning? I'm going on vacation next week, so for 2 weeks, there will be no neurology morning report. So if you're thinking I'm gonna do it soon, but maybe not this week, this is the week. I will be backpacking in Yosemite next Tuesday and not here, hopefully, if it doesn't catch on fire between now and then. Yeah, we won't be doing neurology morning report from Yosemite. I'm gonna hopefully there will be no neurology to deal with in the high country up there. Who would like to discuss a case this morning? Great. Fantastic. Brody. Great. And so do we have ideally someone identifying as a woman who would like to discuss with Brody? And I haven't seen a case, so Gabriella, I think you found one, so great. So maybe if Gabriella and Brody would like to introduce themselves, hopefully that will inspire someone else to join the discussion this morning. Go ahead.
Gabriella, did you want to go first? Or?
No, please go first.
Hi, this is Brody. My pronouns are he and him. So I finished my med school in India, and then I decided to take a break from medicine and do something else, which is one of my other passions, which is computer science and bioinformatics. So I am a master's candidate and a postdoctoral fellow here at Stanford, and researching mostly cardiac arrhythmias and atrial fibrillation specifically in the context of AI and machine learning. And also an internal medicine applicant for the Match 22 season, and thinking of, going back to clinical medicine. I'm kind of starting to miss it. So, and have been following CP Solvers for some time. And I think since the time they started in March last year, probably, and have never presented just because I couldn't get the time, but I would really like the opportunity. And I really believe in the principle of, the democratizing medical education and the way you guys do it. Thank you so much. Happy to be here.
Fantastic. We're happy to have you. Thanks for sharing your interesting journey. We'll be very excited to follow your career and hear how you integrate computer science and medicine. I could think of many applications in neurology, but if internal medicine has got your interest, I'm sure you'll find things there as well. People might have seen a New England Journal a week or two ago, brain-machine interface study, a man who was unable to speak, and computer scientists helped decode his brainwaves so that he could actually speak at about, I forget what the rate was, but there's videos of it on the New England Journal website, sort of amazing, just by decoding thoughts through implanted electrodes. This computer programmers could decode it and have pretty good accuracy of the patient being able to speak through a computer, sort of amazing. Who else would like to discuss with Brody? Ideally, someone identifying as a woman, but we will not absolutely require that if we have no one else. Okay, in the meantime, Gabriella, you want to introduce yourself and hopefully, oh, did someone volunteer and I missed it?
Yeah.
Fantastic. Sharada, great. You're hired. Yeah, you said you've already discussed the case, but not a neurology case that I can remember. So please introduce yourself. Thank you so much. And we'll go ahead and get started.
Hi, I'm Sharada. I am an MS4 at UCSF, currently taking a leave of absence. So taking all the opportunities I can to sort of keep my medicine knowledge progressing and growing. So yeah, excited to discuss, excited to think about neurology stuff, which I haven't thought about in a long time.
Fantastic. I'm a big fan of the year I was off. I took 6 years off between my third and fourth year. And whenever a student asks me, should I take a year off? I say, no, you should take 2. So great. Well, thank you so much, Brody and Sharda, and excited to discuss this case with you. So Gabriella, do you mind giving us just the chief concern, just the chief complaint, and we'll go ahead and get started.
Of course, awesome. So nice to see so many different people here from different backgrounds and interests. So I'm Gabriela, I'm a neurologist from Brazil, and I'm also applying for neurology this cycle. So the chief concern is asymmetric pupils.
Asymmetric pupils, fantastic. So we'll have you both talk a little bit about this. Either can go first as you like. I see you here on my screen, Sharda, so I'll just have you maybe start. What comes to mind when you hear this concern of asymmetric pupils?
Honestly, the thing that comes to mind is cranial nerve 3. And so some kind of process that's affecting cranial nerve 3. And what we think of as causing this would probably depend on when they noticed this problem happening, or I guess somebody else would have noticed. So in terms of thinking about things that could be causing this, we could be thinking about ischemia, we could be thinking about some kind of mass effect, and that could be caused by various things. Anything that causes increased intracranial pressure, which is why I think people are freaking out in the chat. I would also be freaking out. I mean, you could also be thinking about infection, although we don't have any other symptoms that could be suggesting it. But by infection, I mean like something like an abscess that could be pressing. But yeah, when I first saw this, I did not know what to think except very big general ideas. So we'll see. If it's not cranial nerve 3, I stand corrected.
And so tell me this, Sharda, if it is cranial nerve 3, which is certainly one possibility, what would the abnormal pupil look like? In other words, would it be smaller or bigger if cranial nerve 3 is affected?
Okay, let me think about this. I have to reason through it because I haven't thought about it in a while.
That's the best way to do it.
So cranial nerve 3 is connected to the parasympathetic. So that means that your pupil would not contract in bright light. So it would then be larger than it's supposed to be.
You got it. Perfect. And I love that you said you had to reason through it, because if you're like me and you take a certain amount of time off, the things you can reason through will come right back to you, and the things you memorized might evaporate. So cranial nerve, so we definitely memorize, but if you can reason through it, and that was perfect. So that's right. Cranial nerve 3, one of its many functions, which we'll maybe talk about if this is becomes relevant as the case proceeds, is to constrict the pupil. Parasympathetic are small, relaxed pupils, right? And so if there's a lesion of cranial nerve 3, the pupil can't constrict, that pupil will be dilated. And so as you said, if you see that, there's lots of things you could be concerned about, but depending on the time course and context, one thing we could worry about would be some type of mass effect on cranial nerve 3, which, as you said, was causing people to freak out, right? Could this be a herniation syndrome where the uncus, medial portion of the temporal lobe, is pushing on the cranial nerve 3 as it's passing out of the midbrain towards the orbit? Great. So one possibility on the localization side of things is a cranial nerve 3 palsy. And just to go a little further, since you said you want to keep your medicine fresh in this year, Sharada, but no pressure. If this is a cranial nerve 3 palsy, the pupil would be dilated. What other things might you see in that eye if cranial nerve 3 is not working properly?
So it innervates some of the ocular motor muscles. So that means that this is something that I memorized, and for some reason I remember.
Good.
The affected eye would be down and out. So you would see some asymmetry in the pupil itself. And because the muscle has a palsy, then you might have diplopia.
Correct, right? So cranial nerve 3 does all the muscles of the eye that cranial nerve 4 and 6 don't do, right? So it doesn't do superior oblique or lateral rectus 4 and 6. And so if all the other muscles are weak, cranial nerve 6 will still allow the eye to go out, and cranial nerve 4 will allow the eye to go down. So you will have this down and out with a large pupil. And one more thing, if you can remember.
I think I saw someone mention this in the chat, but the pupil wouldn't respond appropriately to light.
I think I can add ptosis.
Yeah.
Yes.
Brody, please go ahead. I've been talking a lot.
Yeah. Nope, I was going to just stick with you, Sharada, for the one side of the equation, then we'll see what Brody has also. But yeah, the dilated pupil, depending on how severe it is, might not react, or might imperfectly react, or might be completely blown. As we say, it doesn't react at all. On the flip side, you'll get a very easy fundoscopic exam in a dilated pupil, which can be very hard right when the pupil is constricted. You may also see ptosis due to the innervation of the levator palpebrae. So some people, it's sort of one of these neurology riddles. They say, well, what would a patient present with a cranial nerve 3 palsy? And people might say diplopia, and you say tricked you, because they won't have diplopia because the down and out eye is closed. And you have to lift it up, and then the patient will have diplopia because the eyes will be misaligned. Right, so if you had a full cranial nerve 3 palsy, you'd have asymmetric pupils because one pupil is dilated, not responding to light, and the lid may be down, and the eye may be also down and out from the rest of the functions of 3 if they're all affected. What are you thinking here, Brody? That was fantastic, Sharda, great. What are you thinking here, Brody?
Right, yeah. So I think my thought process is on the lines of what Sharda said, but I'm trying to also think of the various places where these lesions could result in this, and trying to think along the visual pathway actually, and from the eyeballs to the optic tracts, the ciliary ganglion, and then along that to the brain, and finally the efferent pathway is through pretectal geniculate nuclei, and I'm trying to, I don't know if I got that right, but thinking along that line, on those lines, I think lesions so if there's a pupillary defect, it could be in the afferent or the efferent pathways, right? So in the afferent pathways, you could have there could be optic nerve lesions, most probably the relative afferent pupillary defect, which people very classically see in multiple sclerosis, where there is an afferent problem in one eye, which is why that eye is not really reacting that well, and it probably gives you a paradoxical, relatively a dilation rather than a meiosis, if I say. So that's one of the things, and then so that's the afferent terms, and probably you could have aneurysms in ACOM arteries and stuff, that possible, but which could be pressing on one of the afferent arms and causing afferent defects. And then if you go back, now you're going back into your brain, and then could be, but I am not probably sure that if a brain problem, and the cortical problem would cause a pupillary defect because of the representation, what is that? Representation degeneracy, I guess. So, and because a lot of area would be represented. So, and then finally, again, it kind of condenses into the efferent pathway, where you can have lesions, probably a penial tumor, which could press against the pretectal nuclei, and then moving forward, I guess, through the again, and then I think it builds into the Sharda's point about cranial nerve 3 thereafter.
Fantastic. So you took us to another side of the equation here, right? If the pupil won't react to light, it could be an efferent problem, meaning the third nerve is not able to constrict the pupil. Or you can also see an afferent problem where the light is not actually seen by the eye. And that's almost always an optic nerve problem, though, as Brody said, very rarely you could get that from something in the midbrain. Usually you're going to see a lot of other stuff with it in that context, but optic nerve would be the most common, or very severe retinal disease, but retinal disease to the point of blindness. Usually this is an optic nerve problem. So those are two possibilities. And then there's one more possibility that could cause the pupils to be asymmetric from an anatomical perspective. So a third nerve problem, a second nerve problem, and then there's one other system we could evoke that could cause the pupils to be asymmetric. Any thoughts on that? I can also give a clue if helpful.
The parasympathetic autonomic system, and probably that's again going to play. I know that there are certain conditions where the ciliary, what is that? I think it's when there is a tumor on your chest and you have one that, that kind of goes again on the stellate ganglion, and then it causes a Pancreas tumor, which can cause
what is that pathway, and what do we get from that pathway?
Oculosympathetic pathway.
Oculosympathetic pathway, perfect. Can you tell me a little more about that and what the pupils would look like?
Well, okay. I think because it's going to press on the ganglion, which is sympathetic in nature, I guess that side, the eye will be myotic and probably again myotic, and what else? And there should be a Horner's. I think there should be Horner's on that eye too. Yeah.
Perfect. Okay, so we have all the anatomy on the table, so we can talk about our localization. Brilliant job, Sharda and Brody. So if the pupils are asymmetric, the first question is, which is the abnormal one, right? Because one of them is smaller and one of them is bigger, but how do we know which one is the problem, right? Now, if you see a whole third nerve palsy on one side with ptosis down, that's going to be obvious, right? Or if you see the package of a Horner syndrome, the rhyming syndrome, ptosis, meiosis, and hydrosis, always has that nice sort of poetic sing-song to it, that syndrome, that the lid is down, the pupil is small, and there's lack of sweating sometimes on that side of the face. We'll talk about that if it becomes relevant. But if it's a very obvious asymmetry, sometimes it's clear which pupil is abnormal, but sometimes just the pupils are two different sizes and you're not sure, is the small one have a Horner syndrome or does a large one have a third nerve palsy? So how can you tell? So one thing you can do is observe the pupils in both light and dark, right? Because what's supposed to happen? In the dark, the pupils are supposed to dilate, presumably so we can see better. And in the light, they're supposed to constrict. So we filter the amount of light, right? So if you look at the pupils, some people might say, how do you do that if you're shining the light in them? Won't they constrict? You just shine the light from below. Take the light and shine it from below, like when you're a kid and you take the flashlight to scare your younger brother, younger sister, right? That you're a ghost in the dark or something. Shine it from below and look at the size of the pupils with the room lights on, and then turn the lights off and keep looking. In the lights, when the lights are off, the pupil should dilate, right? And so if there's a Horner syndrome, that smaller pupil isn't gonna dilate like it's supposed to. So if the anisochoria gets worse in the dark, there's a dilation problem, right? One pupil is too small. On the other hand, if the anisochoria is worse in the light, right? It means one pupil was supposed to constrict and it didn't. So the big pupil is not constricting like it was supposed to. And then the dilated pupil is the abnormal one. Some people have physiologic anisochoria, where the pupils are just a little bit asymmetric. Neurologists notice this, that everyone's no one has a perfectly symmetric face and perfectly symmetric eyelids. And especially patients with very light eyes, blue eyes, sometimes you can see this. And the pupils are a little asymmetric and you don't need to call a code and get a CT. And you can tell in light and dark that they sort of behave the same and they both react, and it's probably fine. And they didn't notice until they had a roommate who's a med student who says, oh my goodness, you have anisochoria, and the person gets all frightened, right? So what we need to try to figure out is which pupil is abnormal, right? So then we know, are we invoking the sympathetic pathway, which has this odd course from the hypothalamus down through the dorsolateral brainstem, down through the cervical spine, all the way to C8T1, and then it loops back over the lung apex. This is always on the step, right? A Pancreas tumor at the lung apex, and it travels up, and then the sweating fibers go with the external carotid, and the eye fibers and the lid fibers go with the internal carotid through the cavernous sinus to the orbit. So you can actually localize based on whether there's a sweating defect or not, if the problem is proximal to the carotid bifurcation or distal. We can unpack that if it becomes relevant as the case goes on. So as we're talking to this patient, right, we're looking at their pupils and trying to see which one we think is the abnormal one, if there is any lid problem. Another clue, right? With a Horner's, the ptosis is on the side of the small pupil. With a third nerve palsy, it's on the side of the large pupil. And with a third nerve palsy, usually the ptosis is complete. The lid's completely down. A Horner's, the ptosis is usually actually pretty subtle, where the lid is just a little bit down, a little further down than it should be, and the bottom lid is a little bit further up. But it's something you really have to sort of stare at and say, oh yeah, that I'm seeing a little less of the iris in that eye, but it can be a little bit subtle. So ptosis in a small pupil is the Horner's package, ptosis in a big pupil is the third nerve palsy package. And then Brody said, we often don't think of it in this context of this discussion, but you could have an optic nerve problem where light's just not getting in, and then we'd be able to maybe see the relative afferent defect on the exam. If that becomes relevant, we'll unpack that because it requires even more anatomy, and we've already talked a lot of anatomy this morning. Great, and then as Sharda said, coming back just to first principles, right, we'll want to know what other deficits are there? Who is this patient? Is this a child, adult, older person? Did this happen suddenly? Did this happen over hours, over days, over weeks, over months, over years? So, so those sort of the basic approach to anisochoria. Which pupil is the abnormal one, bigger or smaller? If it's the bigger one, something in the third nerve or possibly an afferent defect. And if it's the smaller one, something in this oculosympathetic Horner's pathway. Great. What happened next, Gabby? The patient had small pupils and then what? Or sorry, asymmetric pupils and then what?
Awesome discussion. So I don't remember specific details from this case, but I'll just tell you like the big picture. So he's a 30-year-old male, around 30, I mean, and he came to the hospital saying that one day before he realized his pupils were asymmetric. His wife also noticed that the pupils were asymmetric, and we asked for an old picture, and we saw that he didn't have these asymmetric pupils before, but he doesn't know if he just realized one day before or if this was there for a long time, because the picture was from some years before. And he denies any headache, diplopia, other systemic illness or recent fever, and he has never had this before. Regarding previous medical history and medications, there were nothing relevant, and from family history, nothing relevant as well. Social history, he lives in Brazil, and I think that's it. Nothing else is relevant there. And he doesn't have any ptosis or any other neurological complaints.
Okay, normally we would stop and discuss this, but I don't think we know any more than we did from the chief concern, right? So I might, unless anyone, if either of you have further thoughts here, I don't have any, I might ask you instead, what are we going to look for on the exam now to try to tease this apart? So I think we started last time with you, Sharda, so we'll start with you, Brody. If you have thoughts on this history, please go ahead. I'm not sure I have any, or just now that we're going to get to the exam, what are you going to look at to try to sort this out?
Sure, yeah. So I guess I do have some comments on the other part of the histories, like he denies headache, which I know that cluster headaches, which are usually more common in males, can sometimes have Horner's and pupillary defects. So that's one thing that you can probably rule out. Then blurry vision, I guess this goes to the point that probably there is not an afferent issue, and also if he has pain on movement of his eyes, which could also rule out, an optic neuritis issue. And then illness, okay, that's probably moot. And then no past medical history, probably a negative history is conspicuous with the sense that, it's you do not have any diabetes or any other cardiovascular risk factors to suggest that you might have had a vascular defect, which would have probably driving the issue. So I guess, and medications, well, I don't think if I can really build on the medication, really, it's kind of broad. So, okay, social history, that's okay. I'm probably not thinking anything coming to my mind right now. And what are we going to look in the examination? I think As far as vitals, I would be interested in looking at the BP and heart BP probably, which can be, if there is if there is after all inflammation or any kind of cardiovascular problem, that would come up in the blood pressure. And then systemic examination, what am I looking for? Okay, most importantly, neuro examination, I guess. Uh, you would most probably want to define what problem that is, and exam the cranial nerve examination, and also to define what kind of which eye is abnormal, right, as you said. So examine that and see which, if it's a dilatation issue or dilatation issue, or a meiotic issue, so constriction issue. So that's probably one, defining the problem. Second, to go ahead and do a full cranial nerve examination. And I think from that standpoint, the ones which really take part in ocular movements and activity obviously is two. And then you could do the swinging light reflex to understand RAPD, and from two standpoint, and also to do to define the any visual field defects by confrontation. And so that's two. Then the other three, I think the three ocular motor, you can okay, obviously you can do pupillary reflex, and then you can check for extraocular movements by using the H. And then pupillary reflex, ocular motor, and then I think that's there. And then also to do any other cranial nerve examination for the other ones, to see for any problems in the brainstem, which could have been causing this. So then reflexes, yeah, I guess it could be relevant. Again, if you are looking for any patchy lesions in the brainstem, you could have some exaggerated reflexes, and that could be again into the could be from my multiple sclerosis standpoint. So, and then reflexes, sensory. Would be interested to look at cerebellar signs, and because of 1 minute, I'm blanking a little bit, but how does the cerebellum? Okay, I'll leave that there. But I think I'll also look for nystagmus. So, and see if there is any kind of nystagmus there. I think that's all I have. Let's see how it goes. Yeah.
Very good. I love that. Every time I always ask you, what would you focus on in the neurologic exam? And everyone always says, ends up saying that, excuse me, the complete neurologic exam, which is always a good answer when you're talking to a neurologist, right? But I agree. The first things you said we're going to be most interested in is what's going on with these pupils, and are there other associated eye movement or lid issues that will help localize, as we said. And then more broadly, since we're thinking about pathways that could be in the brainstem or cranial nerves, are other cranial nerves affected that would give us neighborhood signs that would help us with the localization. I think that's right. I had said we don't really have further clues than that this patient has anisochoria, and you appropriately said, Brody, that, well, there's things that this is probably unlikely to be, right? If there's no complaint of or concern for visual loss, that takes the afferent probably off the table, because those patients usually aren't going to tell you my pupils are asymmetric. They're going to tell you my vision is blurry or dim in one side, and may have pain with eye movements if it's an optic neuritis, but not necessarily if it's just an optic neuropathy, which has a broader differential. And you mentioned a cluster headache, which again is very common on step 1 and step 2, but actually very uncommon in real life. I think I've seen one case in 10 years. How many have you seen, Gabby? It's very uncommon. Migraine is so common, tension headache is so common, and the step would make you believe cluster is the third most common, but it's not common at all. But they can get all kinds of, they can get lid edema, Horner syndrome, anisochoria, all kinds of things like that. But there's no headache here, right? So you took a lot of things off the table. And this patient is awake and talking to us, right? So, sometimes we'll get paged in the hospital's neurology, come as soon as you can. The patient has, a dilated pupil on one side, and we were afraid they're herniating, and you come in and the patient's on the phone, and they say, hold on, there's some doctors here. I don't know what they want. And you say, well, why was there so much chaos here, and the patient has one pupil that's really big, and you see their nebulizer is off their face because they're on the phone and it's blowing into one eye, right? And that, so, another important differential, we talked about the anatomy, and I always say toxic metabolic is the differential for everything in neurology is, drops, pharmacologic. So either eye drops or there is, I forget what, is it a plant or something that people, if you touch it and then rub your eye, I might be making that up. The scopolamine patch that people take for seasickness. Someone told me a story, an older neurologist, I don't know if it's true, that someone had one of these on a cruise and was scratching at it and then touched their eye and had a dilated pupil. And there was a surgeon on the boat who thought they were herniating and actually did a burl on the patient. I don't know if that's true or not, on some tropical island, because they were so worried, and it was just some scopolamine got on the eye, right? So we didn't hear about any medications or drugs, but always on the differential also. But I agree, this is going to now rest on really looking at the eyes, deciding which pupil is abnormal, right? By the one that either is not reacting or changes, as we discussed, in light or in dark. And if there's any other subtle signs, he doesn't report any double vision, which we'd probably have if this was a third nerve problem. So that makes us maybe a little more on the Horner's side of things, versus physiologic anisochoria versus something got in the eye, chemical that made one pupil bigger. So if the patient has noticed the pupils and nothing else, I guess I'd say on first pass, that would make me think more either on the drug side of things, but if we take that off the table, on the Horner side, because the ptosis is pretty subtle and the patient might not notice, and because there would be no extraocular movement, palsy. So just on a first pass, if this is really all we have, or physiologic anisochoria. Like I said, the patient just has asymmetric pupils and just happened to read an article and looked in the mirror and said, oh my goodness, my pupils aren't the same size. I don't know if this is written about or something I've just seen with experience, but I think patients with migraine may be more predisposed to have physiologic anisochoria, maybe slightly more common. I may be making that up, or just something that I've seen. So, okay, we'll be interested to see this patient's eyes. And then if there's, as you said, Brody, any other surprises that there's asymmetric reflexes or weakness or pronator drift or cerebellar signs that say, whoa, 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 this isn't just a pupil case. There's a lot of stuff going on here. So great. So let's hear the exam, Gabby, and then Sharda will have you interpret the exam.
Awesome. So I'm going to share my screen to show you the picture of his eyes.
Oh, perfect.
And then maybe you can comment on that. Can you see it?
Yep.
Yeah, so the patient was awake, he was oriented. The anisochoria was defined as left pupil bigger than right pupil. Anisochoria got worse on the light, and left pupil has had brisk reaction to light. He also had Lightner dissociation, and remaining on cranial nerves, reflexes, coordination, and everything else was normal.
Okay, let's just recap. You said it got worse in the light. Was that right?
Yeah. Mm-hmm.
Worse in the light, and that both pupils were reactive, or one was not reactive? The
left had brisk reaction, the bigger pupil.
The left pupil had a brisk reaction, and it was worse when we saw it in light. Yeah. Okay. And everything else was normal. Mm-hmm. Yeah. Okay. Do you want to show us the picture again?
Sure.
And you didn't tell us, but does the right pupil react?
Yeah. Mm-hmm. It reacts.
So both pupils react, worse in the light and Lightner dissociation. Mm-hmm. Very good. Okay. What are you thinking, Sharda? You might be.
I am trying to make sense of the eye exam. So
me too.
So first of all, in looking at this picture, totally agree that the left pupil looks larger than the right. I'm not seeing any signs of ptosis really. So it does look like it's really an isolated pupil problem. And then thinking about localizing the lesion. So if the anisochoria gets worse in bright light, that makes me think that the left eye is inappropriately remaining dilated and not constricting as it's supposed to be. So that makes me think that the problem is in the left eye. So we have a mydriasis of the left eye. And
Can I just,
yeah.
Sorry, I think I have to make a correction. I think they were equal in the dark and in the light. I'm not so sure about this, worse in the dark, sorry.
So let's, so we all agree the left pupil is bigger. They both react normally, but then light, dark, it was the same, maybe. No specificity. So all the things you said, Sharda, were correct for what you said. So that was, let's just play that one out, even though it didn't turn out to be the case. If you looked at this at first pass, you kind of look at it and say that left pupil looks kind of big, but then you also say that right pupil looks kind of small, right? This is how our vision works. We compare things rather than do absolutes, right? That's sort of evolutionarily what's helpful, right? Not to know something is 3 inches versus 5 inches, right? But one's bigger and one's smaller. So you'd want to know, is the left one not constricting, meaning this would get worse in bright light, or is the right one not dilating, this would get worse in the dark? And Gabby's telling us neither of those were really the case. But what you said was correct, Sharda. If this was worse in bright light, then we're done. The left pupils, the abnormal one, we're somewhere along the third nerve path from the midbrain through the meninges, through the cavernous sinus to the orbit. And if it was worse in the dark, the right one wasn't dilating like it was supposed to, and we're somewhere along that Horner's pathway from the hypothalamus, dorsolateral brainstem, rarely, but possible, cervical spine, all the way down to C8T1, apex, lung apex, carotid, along the path of the carotid, so carotid dissection, not uncommon cause of Horner's, or even in the cavernous sinus, so it gets confusing because both the third nerve and the oculosympathetics are there, and which one wins depends on where the lesion is in there. So now we're saying we have anisochoria, larger pupil on the left, both reactive, no change in light or dark. So take 2. What are you thinking, Sharda?
So I am a little confused, I will say. So it sounds like the pupils are reacting appropriately to light and dark, but they're just not the same size. And so, and the other abnormality, I think, was the Lightner dissociation.
So let's clarify that actually. Gabby, since they are reacting in light, are you saying they're not reacting in near, or they were reacting in light a little bit, but reacting better in near? Because I think I'm confused about that too, Sharda. Your first statement, I'm confused also. So I appreciate you being open about that. And we're going to learn something because I'm also a little confused.
Yes, so sorry. That's why I interrupted you, because I made the whole confusion, and I'm also confused. But I'm trying to recheck everything. So what I think what he had was they both reacted to light, but the reaction to light in the left eye was a little bit brisk, and the left eye constricted more when doing the conversion of the eye.
Okay, so the left eye constricted, when you say brisk, do you mean it constricted normally or sluggishly, slow or?
Yeah, slow.
Slow, okay, so the left pupil is constricting, but a little bit slow.
Okay.
And it responds better to near, is that right? Yeah. Okay.
Yeah, thank you for translating what I'm trying to say.
No, when you say that it's perfect, yeah.
Responds better to near, what exactly do you mean by that?
It constricts more when you do the convergence examination. So it gets smaller when I did that.
Yeah, so the pupils constrict to light, we all know that, but they also constrict to near. So when we're reading, we use close vision.
Okay.
The eyes converge a little bit, the lens changes shape, and the pupils get a little smaller when we look near. So this is really hard to see, but next time you examine a patient with light blue eyes, and you're doing your H, do convergence, and you can see very beautifully that pupils constrict. It's hard to see in patients with darker eyes, but whenever I'm teaching on rounds and there's students and the patient has blue eyes, there's always an opportunity to show this near response. So Gabby is telling us that and pupils are always, eyes are always confusing because it's left and it's right, and it's the patient's left and you're right, and which one is bigger as well. So we're now hearing that the left pupil constricts to light, but is sluggish, sounds like. And with convergence, there's more a brisker response. So how do we analyze that? Yeah.
Okay, that makes more sense now. Thank you for walking me through it. So it sounds like this person, the left pupil is the abnormal one. It responds better, it accommodates better than the pupil reacts. And I see a lot of people in the chat are talking about syphilis. And that is the only thing that I know that causes this response. I know that it has an eponym and I just forget what it is. Yeah, so that's my thought.
Great, and that's a great thought. Yeah, so when you hear Lightner dissociation, it's like med students around the world, wake them up at 3 in the morning and say Lightner dissociation, they say syphilis, right? And we learn that dissociation, and it can be caused by syphilis, but there is a differential diagnosis to Lightner dissociation. It's my understanding of this is actually really interesting. We always think about the reaction to light, but there's proportionally a lot more fibers dedicated to the near response, so that with pathology of the third nerve, the ciliary ganglion, et cetera, the light response is just more vulnerable. Or it may be, when there's chronic injury to a nerve, and then it's sort of there's some regrowth of nerve terminals that you get dissociation between light and near because more fibers sort of come back for the near. Something like that is the story as I understand it, right? So right, the left pupil is bigger. It looks bigger, but it doesn't look huge, right? Like a blown pupil, and it is reacting sluggishly, but more to near. So what do we do with that? Yes, when you hear about this, the eponym is Argyll Robinson. I remember that A and R, it accommodates, but doesn't react, AR. To remember what it does, there is another mnemonic, but it is politically incorrect, which you may be aware of and hopefully has fallen out of use. So I just remember A accommodates but does not, R react is Argyll Robertson pupil. So there is something else there are other things that can do this. Does anyone know, Sharada or Brody, what else can cause this Lightner dissociation?
So I'm trying to think of the problem here. So am I on mute?
No, you're good.
Okay, so I think so there's no problem. So if it's reacting to one reflex, and so it is not an afferent problem. So definitely there is no cranial nerve 3 issue. So the issue is probably in the place, and we also said there is no afferent issue. So the issue is probably in between. So in between would be the areas ranging from the Edinger Westphal and the pretectal nuclei. So in those issues I get, and whereas I think the one which I'm not very sure, but when you do the accommodation, that does that also follow this route of network? Probably not. So I'm thinking if there are issues, so in that area you could have, I'm wondering if there are CNS tumors and which could do this. And the other thing which kind of comes to my mind, but it's probably not relevant, is that I know that diabetes affects these fibers disproportionately, and the ones which cause accommodation, the ones which cause extraocular movement, I guess, is on the periphery. I'm not very sure, or in the middle of the nerve fiber. And so I think that's the other thing that I remember. Yeah.
Yeah, great thoughts. So what you're getting at is when we think of a third nerve palsy, as we say, we think of a whole package of the eye is down and out, the pupil is big, and there's ptosis, as Sharda told us at the beginning, right? Both through reasoning through the pupil size and then remembering the down and out. But interesting, now we really get into nuanced anatomy, right? The third nerve, those fibers, they're separate fibers that are going to each muscle, to the lid, to the pupil, and those pupillary fibers run on the outer medial surface of the nerve. So if you have a compressive lesion pushing on the third nerve from the outside, you can blow the pupil, but still have spared extraocular movements. So in a compressive third nerve palsy, early on, the pupil is abnormal, and then you might have full movements of the eye, and you just have the pupil. That's actually the more concerning sign that there's a compressive lesion, a PCOM aneurysm, uncal herniation, something like that. On the other hand, the rest of the fibers are sort of more inside the nerve. And if you have a diabetic infarct, we had a case on CP Solver's morning report a few weeks ago of a diabetic sixth nerve palsy. You have a sudden onset diplopia, and there's an infarct of the nerve. If it's of the third nerve, you get those inner fibers and you get a pupil sparing third nerve palsy where the eye is down and out. You might get the ptosis also, but the pupil is still reactive. So I'm thinking about Lightner dissociation. I don't think you would see that with a third nerve palsy. So syphilis is definitely on the list here. And the other thing is an AD's pupil. This is not that common. And I used to remember it. AD is ADIE as a dilated pupil that has Lightner dissociation, and there's no other deficits, and it's just some benign thing. The patient, it's just cosmetic. The patient sees it, but it has no deficits. It's more common in young women, and it's sometimes associated with hypo or areflexia of the limbs, also called AD-Holmes syndrome. And there's Lightner dissociation. Over time, as people get older, the pupil ends up actually getting smaller, which ophthalmologists call a little old 80s, like a little old lady, which is kind of a strange name. A little old 80s is the small pupil. I think there's probably a longer list that an ophthalmologist could give us, but with Lightner dissociation, I think of syphilis and 80s pupil as two of the main things. I think you can get it if you had a third nerve problem in the past, and then with regeneration, you sort of get disproportionate reinnervation of the near response compared to the light response, or something like that. Could this patient have a tumor or something pressing on the nerve, or an aneurysm pressing? I suppose that's possible. I don't know, to be honest, if that would give Lightner dissociation. So if that's the case, Gabby will teach us why that's the case. But what is it not, right? It's not a Horner syndrome, right? There's no ptosis, and that small pupil is not the abnormal one. So we're more in the question of what is the differential diagnosis of Lightner dissociation, and I should have a better schema for that, which I do not, since it's not something I see super commonly. And even with syphilis, it's the classic sign, but we don't see late syphilis. I've actually never seen a case of neurosyphilis, though I know many people on this probably have, so I've only read about it. So what would you do next? Sharda, Brody, if we're going to solve this, other tests what tests would you order here? Or ophthalmologists might try to get more information by putting eye drops in the eyes, but I think with Lightner dissociation, probably not necessary. What tests would you be interested in? Try to solve this.
I guess I would be interested in looking at the optic tract. So probably I'm thinking of some imaging, MRI most probably, which would be able to give me the idea of the entire optic tract. So yeah, I think the one, without doing a lot of other investigation, obviously syphilis is on the differential, a VDRL would be prudent, and then MRI. Those are the ones which I am thinking of at the moment.
I think that's right. If we collectively knew more ophthalmology, and we could be somehow convinced that this is just either syphilis or an 80s pupil, maybe you could get away with no MRI. But you have a sluggish pupil on one side. I agree with you. You probably want to exonerate the pathway from the midbrain, third nerve nucleus, as I said, over the through the subarachnoid space. It's going to be in contact with the posterior communicating artery where an aneurysm could compress it. It's going to go through the cavernous sinus where there's a whole differential for what could happen in there. And then it's going to go into the orbit to make sure there's no structural cause, because this is some vague thing in my mind that I'm going to look up as soon as we finish. I think with chronic third nerve palsies, don't quote me on this, that you may be able to get this Lightner dissociation also because of how the third nerve regenerates, but I might be wrong about that. I know what's on my reading list for today: Lightner dissociation, why, how, and differential diagnosis. But based on the things we said, a syphilis test, and I think if your syphilis test was normal, your MRI was normal, I guess you would call this an 80s pupil, which is just a benign thing. I don't think it's physiologic anisochoria, one, because it seems like it's new to the patient, although some things are pseudo-new, right? That someone said your pupils are uneven, so I never noticed that. But they should react. A physiologic anisochoria, that people should react, and this pupil's not reacting normally. So I think structural lesion versus syphilis versus 80s pupil is what's on my list, though I think we're all going to learn something from Gabriella here. So what happened next?
So we made some tests. Recently, I have read about Lightner dissociation, but everything that I was that you spoke about, that it's what I read. So if you could make a tutorial about it, it would be very useful.
Actually, you're reminding me from your neurology schemas that you post. One other cause of Lightner dissociation is it can be part of Perinose syndrome, which you have tweeted about, Gabby, which is from a lesion affecting the dorsal midbrain, where you get Lightner dissociation, lid retraction, upgaze palsy, and convergence retraction nystagmus from usually a pineal lesion. But just Lightner dissociation from the world's smallest lesion, I don't think so, but something else that's on the Lightner list. And I'm glad I know you've read about it a lot. I'm glad I didn't miss anything, but I need to investigate it a little further. Okay, so tell us what you learned and then teach us about Lightner dissociation, because I know you've been thinking about it lately.
Yeah, actually, I don't know why it happens. So I was hoping you could provide me the explanation for that.
I know sort of, but I need to refine it more. I'm learning and trying to actually talk about it. Yeah.
But regarding this case, we made some tests, and syphilis and HIV were normal. We did a lumbar puncture, and CSF analysis was normal. And we also did a contrast CT and angiography. Everything was normal. And there is one last exam that we did that confirmed the diagnosis.
Uh-oh, we all have our eyebrows up here. So it's not an aneurysm, it's not syphilis, and it's not an 80s pupil if they figured it out with a diagnostic test, unless that test was rechecking the reflexes. I have no idea. Sharada, Brody, what's the last test then? Gabby got that they figured this out. Well, I guess I can think of one thing, but it's obscure.
I profess myself stumped. It sounds like I always have trouble interpreting syphilis tests, but I think if the VDRL is negative, my suspicion is much lower for that. Lumbar puncture is negative. That makes me, and the imaging is also negative, so that makes me less concerned about something like a mass or an abscess, and we would have expected to see other symptoms for that anyway. I'm trying to think of other things that can just cause like strange symptoms, and I always think about autoimmune stuff or vasculitis, which I think some people mentioned in the chat. But again, I would like the idea of having an autoimmune disease just with this like one isolated symptom just sounds very strange to me. So yeah, I really don't know. That was just a long-winded way of saying I don't know.
I'm thinking the same things you are and also don't know, but I loved your hypothesis that, well, what was the syphilis test, right? And they are not perfectly sensitive, right? You have the non-treponemal VDRL, RPR, and these change depending on the stage of syphilis, right? And other factors. And you have your treponemal test, your actual immunoassays for antibodies to syphilis. So is the other test another type of syphilis testing that gave us the diagnosis? Technically, the patient doesn't have neurosyphilis if the CSF fluid was completely normal and no positivity there, although those are really complicated to interpret because the VDRL is very insensitive and the treponemal test can actually passively move between the blood and the CSF. So if you see them there, doesn't mean that it's neurosyphilis. But in the appropriate syndrome with an abnormal lumbar puncture in terms of there's some cells and some protein, you could still, and a positive serum serology, then you could be thinking about neurosyphilis. But having just the Argyll-Robertson pupil and nothing else, I don't think we could call that neurosyphilis, though the CDC just put out new guidelines as far as what visual, auditory, and other symptoms can get you to neurosyphilis, which haven't gotten to read yet. So I loved your hypothesis that maybe the next test was another type of syphilis testing and it was still syphilis. There's not too many other tests I could think of. Brody, do you have any sense of what this last test could be?
No, I think I probably do not have anything to add. Other than, I think once he's in the hospital, so I guess I would take the opportunity to do some other routine tests to see if anything else is like diabetes workup or something like that, which would help me just take the opportunity. Again, probably a long way of saying that, I don't have anything else. Yeah.
Yeah, I don't know either. If we're invoking diabetes, it'd be invoking a diabetic third nerve palsy, and that would usually have the opposite pattern, right? The eye movements would be affected and the pupil not affected, or at least the eye movements would be affected and the pupil also. All right, Gabby, you stumped the three of us. What was the next test, unless it was another syphilis test, and you didn't stump Sharada?
So actually the final diagnosis that we have, you discussed a little bit about. So here in the hospital where I worked, we usually do the VDRL and the FTABS. And we do this in blood and the VDRL on the CSF, and everything was negative, as you said. So the last test was to use 0.1% pilocarpine eye drop, and the large pupil has constricted. So the final diagnosis for us was 80s conic pupil.
Very good. So pilocarp, we forgot about diagnostic tests that can include putting a drop in the eye. We vaguely mentioned it earlier, but yeah, with pilocarpine, what you can get is again, I don't know the pathophysiology of 80s pupil, but it's such that if you use pilocarpine, the pupil will constrict. But if it's a pharmacologic pupil, then I believe the receptors are blocked and pilocarpine doesn't help. That's my understanding of the pilocarpine test. There's other ones to look at Horner syndrome, cocaine eye drops, which I presume you are not able to get anymore, but you read about them. Apriclonidine is another one. You're looking for receptor hypersensitivity and releasing other things from that third order neuron in the Horner's pathway. But very clever. The last test you withheld was a bedside test, which I love, which is putting pilocarpine in there. And correct me if I'm wrong, Gabby, I know you've been thinking about this lately. I believe that's to distinguish an 80s pupil from a pharmacologic pupil, right? The pharmacologic will not dilate and the 80 or will not constrict and the 80s will. Is there another, am I understanding that right?
I don't remember about the pharmacologic, but from the physiologic, yes. The physiologic, I think it wouldn't constrict.
Great. Okay. So great case. We got to think about pupils, which we haven't talked about before. And we got a diagnosis that allowed us to think through a lot of other things, but come to one might be new to some of us, and remind ourselves that not all tests are blood tests and scans. So we're putting a drop in the patient's eye, which is brilliantly withheld detail, Gabby. we'll have Valeria do the teaching points, but Gabby, before we do that, did you have any teaching points on, I know you've been doing a lot of neuro-ophthalmology on your neurodrology website. Anything you wanted to share with us?
Yeah, so everything, when we talk about eyes and pupils, everything confuses me a lot. So when you said that earlier in the meeting, I was like, wow, I'm not the only person. So every time I study this, I learn something new. And regarding the Addis pupil, I just wanted to share that in young women, it is usually associated with hyporeflexia, which was not the case of this patient, and he was a man, but it's more common in women. And I think maybe I confused you a little bit with all the exam findings, but we got in a final good pathway, and I could learn a lot with your discussion. So thank you.
Great, well, thank you. We haven't had an anisochoria case, so that allows us to think through that differential and put Lightner dissociation on our reading list, but at least we'll remember that we should think of syphilis, but that there is a differential, that 80s is the other main thing. Perinose syndrome is super rare. And like I said, I think the physiology is that there's just more fibers for the near response than the light response, and that the light response is therefore more vulnerable to pathology. But I am having some vague memory of also chronic third nerve injury. The regeneration favors the near pathway for some reason, or something like that, but I'm going to read about it, and we'll know more the next time anisochoria comes up in this conference, hopefully. Great.
Is this something which comes on acutely, or it would have been there all the time? The patient is just getting to notice it right now.
Yeah, pseudo-acute. It's the second one. Yeah,
okay.
Probably it's slowly getting bigger, and just like if you live with someone, their hair is getting longer, they're losing weight, they're gaining weight. You don't notice, but the people you only see on the holidays, you say, oh, you grew your hair, or oh, you lost weight, oh, you gained weight, whatever. Those things happen over a longer time frame. And similarly to this pupil, one day, you're brushing your teeth with your eyes closed, and the next day you're brushing with your eyes open, and you realize, oh, that doesn't look right. And if you're a neurologist, you start shining lights in there, right, and trying to figure it out. Fantastic. Okay, Valeria, do you want to give us your teaching points?
Well, I actually had to leave, but I can sort of read them for her. Really interesting case, Gabby. Thank you so much. And Brody and Shara, it's just amazing discussion. Eyes are so tricky because there's two of them, and they sometimes relate to one another, and sometimes they do things on their own. So whenever you're thinking about the tracks, you really want to start anatomically, I think works best. And think what can be affecting the pupil in this case. And of course, it's not that simple, but it has certain aspects of it, and you can attack them one at a time, as you did in this case. So in thinking about asymmetric pupils, you can think, is it something in the sympathetic system or in the parasympathetic system? And so if it's sympathetic, you're trying to think about like a Horner's type of syndrome, which is the rhyming syndrome of meiosis, anhydrosis, and ptosis, and that's going to be ipsilateral to the damage. When you're thinking about parasympathetic, you're thinking about cranial nerve 3, and the clues for that are also ptosis and diplopia with extraocular eye involvement. It's really hard to narrow down which one is it. So you really have to think, how do they react with light? And for that, I think it works best if you understand what's normal. So I think, let's see. Normally, the sympathetic system causes, now I messed it up in my head. Let me think about it for a minute. So normally,
perfect.
Yeah, I'm so sorry, but it's always a mixture. And Aaron actually has this really good mnemonic. So mydriasis is like big pupils because it's the longer word, and meiosis is like the shorter word. So it's the smaller pupil. So let's see. When you have the sympathetic, it's gonna allow you to see more light. It's gonna cause like larger pupils, mydriatic pupils normally, and the parasympathetic is gonna allow you to close down the pupils, and it's gonna cause meiosis normally. So now that you know normally, you test that with light, and it's gonna let you know if it's a problem in the pupil dilatation or the pupil constriction. That's really hard to do. And then it's not the only test you can do, but that allows you to test cranial nerve 2 and cranial nerve 3 if it's the parasympathetic or cranial nerve 2 and the sympathetic system. You can also test for Lightner dissociation, which for light control. Oh my God, I can't do this. I'm getting so mixed up, but that's eyes for you. I'm so sorry. You can also test for accommodation reflex, which when you're testing it, you bring something closer and your eyes should constrict. And that's normal. And then you have to test both of them, which was done in this case. What's normal and what's abnormal, and if they're both equally normal or equally abnormal. And if they're not equally normal or abnormal, you call that Lightner dissociation. And there's some really cool syndromes that can cause it. Like historically, it was syphilis. And a lot of the neurological exam is based on neurosyphilis. Fortunately, that is not as common as it was a couple hundred years ago, but it was like a good test. And as Gabby's team did, test came back negative. And you have to remember not only about syphilis, but the differential diagnosis, which in this case were an 80s pupil, Parasympathetic syndrome, or a cranial nerve 3 syndrome. They did all of those tests. Nothing came back positive. Syphilis testing came back negative. There was no aneurysm. And then they tested for the pupil. And how you can confirm an 80s pupil is with constrictors like pilocarpine. And if they respond to that, then you confirm the diagnosis, which was the case. Really interesting. And I learned tons. I'm sorry if
Great job.
Totally confused you even further with the teaching point.
No, you did it perfectly. And you kept saying, I don't know, I have to think through this. And you said we all did this. And I think this, speaks to this, just sort of medical education, right? We're taught so many things that we memorize, and then some of them just stay with us, ptosis, meiosis, anhydrosis, even if you don't remember what they mean, right? It's just stuck in there because it sounds good. And yet the things that we understand are the things you can always open up your mental suitcase, take out, smooth it out, and remember it. And just as you did, Maria, was perfect. You said, well, wait a second. If I'm running from the tiger, I need my pupils to be dilated, so that's sympathetic. So if the sympathetic doesn't work, that pupil will be small. Oh, that's Horner syndrome, right? And then the other one is the other, right? If the pupil, the parasympathetic, you're relaxed, you're chilled out, your pupils are just tiny and hanging out, right? Then that's parasympathetic, and that's the third nerve. And if that doesn't work, the pupil will be big. And the light dark, you can, maybe some people can memorize that, but I always have to think through, okay, if I'm shining the light on both eyes and the anisochoria is worse, light is supposed to constrict them. Oh, so the dilated pupil is not getting smaller. It's that side, it's the third nerve thing. Oh, in the dark, it's worse. The dark, they were supposed to dilate. So that means one dilated and the other didn't. Oh, the constricted pupil is the abnormal one. That's the Horner's. But every time I also have to, so no one should be apologizing, saying this is confusing, I have to think through it. It's confusing and you have to think through it. And if you become a neurologist or an ophthalmologist and think through it enough times, you can just say, yeah, it's ptosis, small pupil, meiosis, that's Horner's, is parasympathetic. It's, see, I even said it wrong. It's the sympathetic pathway, right? And if it's a big pupil, it's not responding to light, right? It's somewhere along that third nerve pathway. But you have to do it every time. And the eye movements we've done before too are like that too. And that's why I always do them with my hands. So this one's going this way. This one's got to go this way. So this muscle, this nerve, this muscle, this nerve. So that's the beauty of eyeballs. And if people like eyeballs, you can be an ophthalmologist, but you can also be a neuro-ophthalmologist, which you can become through ophthalmology or neurology. And my colleague, Sashank Prasad, who you see on Twitter, who's a program director in Boston, is a neuro-ophthalmologist. And he would tell us so many amazing things at Morning Report about how the superior rectus subnucleus of the third nerve nuclear complex is crossed. And that's because back when you were a fish and your eyes were on either side and not together, and all these amazing things about eyes. So the eyes are the window to the soul. I forget which poet said that, but we always say the eyes are the window to the nervous system because you can learn so much from examining the patient's eyes. So great case, Gabby, well presented, great twist at the end of the final test, and great discussion on Brody and Charlotte on a very hard topic, but just reasoning it through, and great job picking up the teaching points, Maria, at the end. Perfect, because we got to learn from how you think through it, which was absolutely perfect and came to the right answer, which is much more teaching, much more learning, right, than just saying X equals Y, Y equals Z, and so that's this, and A equals B, B equals C, so that's this. So fantastic, and I'm gonna go read about Lightner dissociation. So next Tuesday, I'm not here. The following Tuesday, Sarah, I'm not here. So if you've been wanting to discuss a case, it's time. If you've been thinking about preparing a case, it'll be time in October, and I'll be very excited to see you then. Thanks again, everyone.
Thank you.